cases together. We were just chatting before starting about COVID-19 here at some locations in the United States where things have been calmer for a while, starting to be problematic again, particularly in unvaccinated people. But we have someone on my team right now who had the vaccination, has it. However, we've emphasized to him and his family has a relatively much more mild case than he would have had without it. So just a great reminder that for everywhere where vaccines are available, and I know that is not everywhere in the world, we have to continue to do our best as a community to get the message out there, because this virus is certainly here, and many of you know that very well from your own experiences just over the last few months, wherever you are. Ravi is excited to discuss. Fantastic, Ravi. We love to have you. And Colleen, oh my gosh, wonderful. So we've got two discussants, and Kirtan is going to present the case. So maybe we can start sharing the Valeria or Gabriel's screen. And in the meantime, Ravi and then Colleen, if you guys want to say hi and introduce yourselves, that would be great before we turn it over to Kirtan.
Good afternoon. I'm Ravi, tuning in from India.
Thanks for being here, Ravi.
Hi, I'm Colleen. I'm in my last year of medical school at UCSF.
Thanks for being here, Colleen. Excited to have you. And Kirtan, want to say hi and let people know who you are before we kick things off?
Sure. So myself, Kirtan, I'm a final year medical student from India, and it's my first time presenting a case on Wednesday to you guys. I'm so excited for that. And I'm so happy to see my friends Valeria and Gabriel here. And we all know that Colin and Ravi always does amazing job. We have seen them discuss before too. So I'm excited for today's case.
Great. So we'll kick things off with you. Excited to hear you present. And maybe Colleen, you and I can pair up and kind of go through the first segment of the case, and then we'll alternate with Zavan and Ravi subsequently. All right, Kirtan, we're ready.
Sure. So this is going to be a short and sweet case. And usually in medical journals, we have got a title that somehow give hints to the final diagnosis. So I have done, that nice tweak to my case. So the title for today's case is Double Trouble, right? Double Trouble. And now for the chief complaint, the patient has fingertip pain and paresthesias. Giving you a bit of HPI, we have an 18-year-old male who presented with the history of gradual worsening of pain in the distal aspects of right and left hand. He was relatively all right 1 year back when he developed the pneumonia, and it was due to the Mycoplasma pneumoniae, and he was appropriately treated for that. However, following the infection, within a period of 1 week, he started developing occasional fevers up to 99 degrees Fahrenheit nearly every day, along with onset of finger pain. And repeated evaluation was done, which was negative for any persistent foci of infection in the lung or any evidence of pleural pathology. And the CBC during these episodes was positive for fluctuating thrombocytopenia as well as anemia. The lowest platelet counts noted, the nadir was 80,000. And for the anemia, the hemoglobin that was lowest being recorded was 10 grams per deciliter. The pain in the fingertips was followed by the development of gangrene and frank ulcerations in the left fingers, to the point that he required skin graft to replace the damaged skin, and symptoms were noted to be worsened by cold and exposure to wind. And as for the review of systems, the patient denies finger erythema or cyanosis, any evidence of weight loss, night sweats, cough, chest pain, any rashes, dizziness, headaches, diarrhea, or abdominal pain. So all of these were negative complaints. And I guess this much is enough information for you to go on. What do you think?
Wow.
Okay. Wow.
Go for it, Colleen.
What a start. This is fun. Okay, so this is a pretty young man, which I think is something that I just want to make note of. So thinking about fingertip pain, I would first kind of think about what the source of that pain is. Is it coming from the joints? Is it coming from the nerves? Is it coming from, in this case, maybe decreased vascularization of the fingers? And then kind of thinking about this patient's background. So having a recent mycoplasma infection, I think if I'm remembering correctly, you can get cryoglobulinemia from this, which, could explain these CBC fluctuations that you're describing. Also thinking about other types of immune diseases that would be unrelated to his mycoplasma diagnosis that can cause finger pain. Thinking about like a Raynaud's type picture, thinking about just other connective tissue diseases that could present this way. What else? Gosh, there was so much in this first aliquot. I think the description that this tends to be worse in the cold is relevant. Makes me think more of like a cold agglutinin disease, or I know some of the other kind of like Raynaud's type presentations can be induced by cold. I think that's where I would start thinking about him.
Fantastic, Colleen. Just such a nice way to think through what the pain could be, as well as layering on what we know about his recent mycoplasma infection. And that's exactly what my brain started doing. I think first, having a framework and a way to really figure out what this pain and tingling is in the fingers. And I'll say the sort of word I supplanted for this syndrome in my mind is he's got a very distal neuropathy in his upper extremities. And I think from there, sort of building a schema on what could cause the pain and tingling in the distal upper extremities is sort of a first step of this. And you gave us just a really beautiful framework for that, with everything from vasculitis, kind of related to his prior infection being on your list, with cryoglobulinemia coming up already. But then also, I think even stepping back, any kind of nervous inflammation or injury that happened related also to whatever treatments and course he went through pneumonia would be helpful. And I think that's where sort of knowing how the infection was treated and what was going on would be really important. But the fact that he's also got these kind of ulcerations also, right? The fact that he needed a skin graft for this suggests that if the nerves were the only thing damaged, that really doesn't fit here. But in fact, very distal perfusion is coming out there as well. And so I think expanding and making sure neuropathy is the right framework for this versus kind of small vessel malperfusion for any reason. And that's where we can really open up what causes vasculopathy. And it certainly comes down to categories of vasculitis, small thromboembolic disease, and of course, just primary sort of injury to that area as well, which we don't have on this history. So Colleen, you just tackled kind of the pain, the paresthesias, and the ulcerations with this really well. And I think we need to be very careful about kind of how we label those syndromes to sort of build the right thing on top of it. I'd say the other thing that I really liked is you also started pulling your knowledge of mycoplasma pneumonia infection complications also to sort of layer onto the framework for the fingertip disease. And I think there I'll just make a couple comments about mycoplasma in general and what it can do. Of course, we know it best for its most common respiratory infection syndrome, which can be pneumonia, which this gentleman had, but it can also be more simple upper respiratory or bronchitis disease also. But where it gets interesting is the other organ systems that can be involved when someone has mycoplasma infection. And Colleen has beautifully already discussed two hematologic complication of the cold autoimmune hemolysis being a factor. cryoglobulinemia associated. And then very importantly, anytime we talk about sort of skin changes distally in someone who's had mycoplasma, there is a rash syndrome that can come after mycoplasma as well, which is very inflammatory and usually involves a mucositis as well as a rash that often has target-like lesions that look almost like erythema multiforme, but is a distinct mucositis induced syndrome with rash in mycoplasma. That's really quite striking and painful, but it looks like right now we don't have involvement at all of the oral mucosa or other areas, making that less likely. Mycoplasma, I think, also can cause aseptic meningitis. I think it can cause cardiac complications. So there's a lot from that particular infection. But Colleen, I think you've done a stellar job just sort of overlaying that infection with conditions that can cause kind of distal pain and ulceration. And we'll see what happens from there with more info from Kirtan.
Yes. So as usual, amazing discussion by you and Colin. Thank you so much for the history and medications. There is nothing there. For the family history also, there is no significant family history. For the social history, patient is a university student and patient denies alcohol, tobacco, smoking, or illicit drug use, no allergies. As for the physical examination, the vitals were all right. The temperature was normal, heart rate of 88 beats per minute, BP of 118/78. The patient was setting at 99% on room air. The respiratory rate was 16. And the general examination was all right. And the mucosal examination, as you rightly asked for that, so there was no evidence of any aphthous ulcerations or erythema in any mucosa. The conjunctiva were clear bilaterally. There was no evidence of jaundice or pallor in those conjunctivas. As for the extremities examination, which was only the significant part of examination, there was darkening of the second and third digits on the right hand. Apart from that, there was dry gangrene on fourth digit, and there was presence of skin graft on first and fifth digit. All of these things in the right hand. And apart from that, the neurological examination was all right. And I guess that's it for the second aliquot.
Thanks, Kirtan. Ravi, what do you think?
Yeah, I agree with the cryoglobin. In addition, I would like to add on to hyperviscosity syndrome. In addition, what caught my eye was the thrombocytopenia and anemia. I was also thinking of like TTP could with the hypercoagulable with thrombosis in the hand, the anemia and thrombocytopenia. I was also thinking of like TTP. So in the physical examination, which concerns was the blood pressure. He has hypertension of 180. That is suggesting me either he may have like a renal failure. He's young, he's 18-year-old male. So hypertension with 18-year-old male, he may have, we had to look at the laboratory data. However, I'm thinking, oh, I'm sorry, it's 121? Oh, I'm sorry, 118, never mind. Sorry about that. I thought it was 180. Coming to the examination, yes, he does have the gangrene at the fourth digit and darkening of the second and third digit, which is consistent with the decrease of perfusion and ischemia. Yeah, I'm thinking about like hyperviscosity syndrome. And yeah, my next laboratory data includes like, if we need to do like cryoglobin workup and look at the complement levels.
Awesome, Ravi. Totally agree. And yeah, Colleen and Steph did an amazing job with the differential from the first aliquot. And I don't think we have, too much more new information to go off of. When you misheard the elevated blood pressure, it made me think about this sort of like learning strategy of that Gurpreet Dhaliwal, I think was the first person that I kind of heard this idea from of, whenever you have a case, even if it's a straightforward case, to essentially do like self-simulations of different versions of that case, right? To ask, okay, this seems like, a very straightforward case of leg cellulitis or whatever, right? But like, how would I think about this case differently if, if blank, if there was peripheral eosinophilia, right, in addition. So in this case, like, even though it was a misunderstanding, I was like, I actually really like loved hearing your, you know, the fact that it caught your attention that this 18-year-old guy was so hypertensive, and how you were trying to tie in potential, you know, renal involvement of this process as a mechanism of that. And again, even though it didn't prove to be the case in this case, that thought exercise essentially prepared you, right? Like helped you see a slightly different version of this case and helped you think about the way that might happen. And by the way, the same patient, like a week from now, might become hypertensive, right? And having gone through that thought exercise, you're suddenly more prepared to take care of even this patient who may evolve in the future. So it was good that we misheard 180, which is both understandable and again a way to sort of like push our learning even further. You know, you're thinking about TTP. Let's build on that a little bit, because I think it's a great thought. Anytime you see anemia and thrombocytopenia together, you should consider you know, the entire differential for what are called the thrombotic microangiopathies, right? The clotty, small vessel diseases. So and what happens in all of these diseases, all of these thrombotic microangiopathies, TMAs, is that you have a propensity for small vessel thrombosis that then leads to like a consumptive coagulopathy and then to a microangiopathic hemolytic anemia, essentially. So you get a thrombocytopenia, anemia, and oftentimes some end organ effects of you know, the organs distal to these circulatory clots being ischemic and thus just, you know, not working right? So, and the telltale sign of all thrombotic microangiopathies, in addition to the CBC, is that the hemolysis is intravascular. So you get not only an elevated, you know, LDH like you would in, you know, even autoimmune hemolysis, for example, but you also get schistocytosis, and you get a depression of haptoglobin because again, the hemolysis is intravascular. So anytime you see this pattern, it's really important to check your LDH, to get the smear and look for schistocytes, because I'll cover the differential in a second, but basically all of them are very serious diseases that need, you know, very time-sensitive diagnosis and treatment. So what are the thrombotic microangiopathies? Colleen, Ravi, throw some out. Other than TTP, thrombotic thrombocytopenic purpura, what else can do this?
HUS.
Hemolytic uremic syndrome, and that can happen either following the, you know, the typical HUS following a diarrheal, right, Shiga producing illness, or it can be atypical HUS that doesn't produce that illness and is mediated through a different mechanism. What else?
Sorry, I don't have a great schema for this. I don't know if I can name any more than that.
Malignancy, like AML, CML, like lymphoma.
Ravi, thank you. So Colleen, and thank you. That's totally normal. But I'm glad to at least give y'all a chance to rack your brain for a second. And even if you are or aren't able to come up with, you know, the full differential, that was still giving it a try still will make the learning more durable now that you hear it. So Ravi, yes, some cancers can do it. Usually though, it's actually the more sort of mucinous solid tumors like pancreatic cancer, gastric cancer, and their metastatic states can cause this just sort of like an extreme of a hypercoagulable state that can sometimes present with a thrombotic microangiopathy as opposed to just like big vessel thrombosis. So advanced mucinous malignancies are on that list. Antiphospholipid syndrome, okay? And that is one where, whereas, you know, TTP and HUS tend to have a predilection towards the cerebral, you know, circulation in the case of TTP, and the renal perfusion and function in the case of HUS, antiphospholipid syndrome often can present with anemia, thrombocytopenia, intravascular hemolysis, but oftentimes more like acral distal ischemia, digital ischemia in the feet, in the hands. Sometimes people's ears, tips of the nose, tips of the penis can become ischemic and necrotic. And it's a really, really bad situation when you sort of like get into that. The other kind of a common one is disseminated intravascular coagulation of whatever cause can cause this syndrome, but generally a lot of times it's not as like fulminant. It doesn't tend to like dominate the clinical picture. And then one that is really easy to miss is scleroderma. And scleroderma renal crisis, sometimes, with overt renal dysfunction, but initially it can also just present with, these cytopenias and sort of peripheral neuropathy, ischemic changes, things like that. The last category is drug-induced. So certain medications, like certain anti-neoplastics like gemcitabine, but also more common medicines like clopidogrel, tacrolimus can all induce sort of a thrombotic microangiopathy syndrome. And the key is to recognize that they're potentially culprit and discontinue them. So I think that's one way to sort of like bring in the CBC findings a little bit more closely. But all of these things that I've actually named don't necessarily follow the narrative of like it started after / was triggered by mycoplasma necessarily, at least not that I know of. I wouldn't be surprised if there's reports of sort of a, antiphospholipid antibodies syndrome, being triggered by that, but I just don't know. I'd have to look it up. So I'm still with, Colleen and Ravi, you and Steph in thinking that this might be the more typical kind of antibody mediated and cold precipitated agglutination and thus hyperviscosity and hypoperfusion of cold agglutinin disease along with the hemolysis. But I also don't know, do y'all know if that can really like self-perpetuate for a whole year and not resolve? I wouldn't be surprised if it could, but I just don't. I haven't seen enough cases to have the experience. So maybe we can see what the laboratories look like now and keep building on a discussion afterwards.
Yes, sure. So as I told you, it's a short and sweet case. So you guys already are on the right track and have almost nailed the diagnosis. So now for the hemoglobin, the patient had hemoglobin of 9 grams per deciliter, the MCV of 90 femtoliters. The reticulocyte count production index was 4%, which is considered as elevated reticulocyte count or adequate reticulocytosis. The WBC count was normal. The platelet counts were 110,000. So it was fluctuating between 100 and 120,000 all through hospitalization. The basic metabolic panel was normal, except for the fact that the APTT was elevated at 110. And interestingly, it doesn't correct with mixing studies. So we did the 1:1 plasma mixing and it never corrected. The INR and PT were within the normal range. The LDH was elevated at 330. Heptoglobin was low. Coombs test was done, which was negative, and it was actually repeated thrice, and it was negative on all 3 occasions. And given the fact that patient had recurrent fevers and everything following infection, we even checked for dengue and chikungunya. So those infections were not there. So dengue and chikungunya IgM were absent. And given the fact that India is endemic, we usually always check for that. So dengue chikungunya was all right. We obtained the peripheral smear and there was no evidence of any agglutination. There was no evidence of cystocytes. There was no evidence of microcytosis or poikilocytosis. So the RBCs were normal shaped and size. The platelets were a little bit less, and that was it from peripheral smear. And there are a few more laboratory data before the final diagnosis. So do you want me to give that now or we can wait?
Let's stop here and we can just share what our thinking is at this point. There's a lot to go through here, Colleen. We can tackle it however you'd like to.
Yeah, let's see. I mean, we kind of already knew what the CBC was going to be just based on like the first aliquot. So I don't think anything about that is very surprising. I think, you know, noting that it's a normocytic anemia is somewhat helpful. And since the reticulocyte count is so high, we know this isn't like a primary bone marrow process or any kind of decrease in production. I think, so for like the heme labs, so the PTT is telling me that so like there's something is going wrong kind of in the intrinsic, or I'm sorry, not the intrinsic pathway of the coagulation cascade. The LDH and the haptoglobin suggest that there is some hemolysis happening. The fact that the Coombs test, or I'm sorry, there's a mixing study that did not correct. So that suggests to me that there's some sort of like an acquired inhibitor. So I think I always have trouble with PTT because I know that there are some things outside of the coagulation cascade that can affect that I'm not remembering very well right now. But I think that these labs would be consistent with like a cold agglutinin disease that's causing hemolysis.
Yeah, I think you've tackled just some complicated labs really well. And I like what you said, right? We knew about the anemia and the thrombocytopenia. The question comes down to why. We got a really nice discussion from Ravi and Zavan about is there, in fact, destruction of the red blood cells and consumption of the platelets from a microangiopathic process, right? From a disease in the small little blood vessels. But we learned that's really defined by having schistocytes on the smear, which we don't have. So we're kind of now a little less worried about sort of a primary microangiopathic process, given that we know the red blood cells aren't low and getting destroyed because of intravascular destruction in those, you know, little clots in the blood vessels. But we see that there is, I'm just pointing out, so with the LDH and the haptoglobin is low, right? The red blood cells with the normal bone marrow count, right? They are being kind of destroyed somehow. So the question is what's actually driving that peripheral destruction. The Coombs test being negative is really helpful for us when we're looking for, right, autoimmune destruction of the red blood cells. And I assume in this case, Kirtan, this was both for sort of warm and cold. Were they looking at both IgG and IgM antibodies in this case?
Sure. So IgG, IgM, and even complement levels, so they were absent. Yeah.
So really kind of making us rethink the discussion of, you know, is the cold agglutinin disease with IgM autoantibody destruction of the red blood cells at play here, right? With the Coombs negative times multiple times, I think we'll have to sort of really think and take a step back about what's making those red blood cells actually get destroyed. And then comes in the PTT, right? And you're spot on, Colleen, that with adding, right, normal blood back to it, we're showing that it's not just a deficit of one of those intrinsic pathway factors, but likely an inhibitor there. So I think we need to really put together what can cause an elevated PTT while also leading to, right, kind of peripheral destruction and ulceration of these fingers, while also leading to some red blood cell breakdown and platelet consumption. We've come up with a really big list of things. Is there anything that we've chatted through, Colleen, that you think might kind of start being able to fit the bill with some of those, some of those categories?
Sorry, let me just look at the list of things that we wrote down.
Yeah, it was a really big list.
You know, I mean, so we had a discussion actually a couple of days ago on VMR about acquired inhibitors, and we talked about kind of a few different categories of that. So autoimmune diseases, like paraneoplastic syndromes, and oh, there was one more that I'm not remembering. Sorry, Steph, maybe you can help me out here.
Yeah, no, I think you're thinking very rightly through, you know, just as you said earlier, is an acquired inhibitor here at play? I don't have an association of connecting that with what's going on, but this is an interesting situation where you said other things outside the coagulation system can elevate the PTT. And in this particular case, I think we should maybe come back to the antiphospholipid antibody syndrome diagnosis and just sort of unpack what we know about that. That, as we discussed before, can cause a kind of microangiopathy, vasculopathy that could explain some of the ulceration as well as the hematologic parameters here. And then very often what tips us off to thinking about that diagnosis, even when the symptoms aren't as extreme as this 18-year-old is having, is a otherwise unexplained elevation in the PTT. Often due to the presence of lupus anticoagulant. And that's tricky, right? It's a bit of a misnomer with the word anticoagulant being there, but not in fact leading to a tendency to bleeding, but in fact leading to a tendency to thrombosis. So this is a very unique situation where when we usually associate a PTT with bleeding predilection, in this case, we're saying this patient probably has kind of a microthrombotic disease with now the high PTT making us think of that unusual exception of the lupus anticoagulant, and I'm sort of putting air quotes around that, being present actually as a sort of prothrombotic factor that might fit into the antiphospholipid antibody syndrome. So I think at this point, thinking about that as sort of the vasculopathic process affecting his fingers, affecting his blood counts, and making his PTT be high without bleeding risk, but in fact clotting risk, is sort of the direction that we're heading in now. I don't know, there's still kind of other things to unpack here. I don't know if Ravi or Zavan, you guys have other thoughts at this point, but I think we definitely need to start going after the antiphospholipid antibodies, kind of all of the different sets of them, to start unpacking this case here.
Yeah, I agree completely. The differential diagnosis with antiphospholipid syndrome also includes like HIT. If patient was in the hospital, received a heparin while he was hospitalized, that's one possibility. Heparin-induced thrombocytopenia and causing thrombosis too. Yeah, you already mentioned lupus. The other thing I was gonna mention is the PTT, which is not corrected with mixing studies. I doubt he has hemophilia. I was also thinking about Ptt elevation. They get corrected or not corrected, I don't remember. That's one thought I had. That's great. Thank you.
Thanks, Ravi. Yeah, I think these latest labs do change it a little bit. I agree with you, Steph. Antiphospholipid syndrome would tie everything together basically. Just the only question is just the timing with the mycoplasma. But like I said, you know, we know mycoplasma can induce a lot of weird immunologic phenomena, and probably won't be a surprise if this is one of them. I think I guess I'll just add, like, it's tricky to interpret when you have this like elevated PTT and then you do the lupus anticoagulant screen and it's and it's positive. Anytime you're exposed to most anticoagulants, but certainly heparinoids and warfarin, you can have just a false positive lupus anticoagulant. But I think in this context, the other antibodies for antiphospholipid syndrome, the anticardiolipin antibodies, as well as the beta 2 glycoprotein would be more specific if they were positive. And yeah, I guess that's all I'll add.
Back to you, Kirtan.
Sure. All right, so we got the CRP and ESR, which was normal. We got a bunch of serologies. So the patient was HIV negative, HBs, AG, and HCV serologies were non-reactive. We did the syphilis test, which was also non-reactive. The patient had ANA, double-stranded DNA, Smith antigen, Rho antigen, La antigen, ENCA, all of them being normal. Complement levels were within the normal limits. We obtained the topoisomerase and centromere antibodies, which were also normal. And meanwhile, all during the course of hospitalization, we provided the patient with nifedipine, but nifedipine relieved the pain only a little bit, and there was no effect on progression of lesions. So patient was still feeling pain, and the lesions were actually progressing through his fingers. And I guess this is all the set of data that I have to give. And in the last aliquot, I will give you one final serology that we obtained, and then we will reach to the diagnosis. So do you want to have a final say?
Nothing further to add. I do think that checking a lot of these autoantibodies was very, very appropriate. Yeah, I mean, even if you're diagnosing antiphospholipid syndrome, a lot of times it is part of a broader syndrome, coinciding with lupus that can have other manifestations. So I think screening with these other autoantibodies was appropriate, and it's overall probably good that they were negative.
All right. So as you guys rightly mentioned that it had to be antiphospholipid antibody syndrome. So basically we started the differential with primary Raynaud's and then secondary Raynaud's. So we ruled out all the possible causes of secondary Raynaud's. For example, chilblain lupus, because there were no evidence of lesions persisting on the fingers, because chilblain lupus can also present in similar way. Apart from that, the hyperviscosity part, which we tackled in the first aliquot. So we checked for the myeloproliferative neoplasms. There is no evidence of that. We also look for Burger disease, thromboangiitis obliterans, all the rare diseases like Monk-Bugs medial sclerosis, but nothing was consistent with our laboratory findings. We looked for the embolic phenomenon, so there was no evidence of any infective endocarditis, no evidence of polyarteritis nodosa, because patients with pain usually have hypertension, so there was not in our case. And the final key was the infection part. So initially when the patient came to us, I was also worried that how to join the infection part. But then I thought that let's keep the infection outside. Let's just focus on the Coombs negative hemolytic anemia and elevated APTT. So if you look at that, then that is classic for antiphospholipid antibody syndrome. And furthermore, the mixing studies won't correct it because as the Colin rightly mentioned that there are some factors outside of the coagulation cascade which plasma can't provide. So things like calcium, things like phospholipid antibodies. So APTT and dilute Russell Viper venom test, that is DRVVT, will only correct on adding the phospholipids. So that is the diagnostic criteria. So after adding the phospholipids, the APTT actually corrected. So it was further, last nail in the coffin kind of thing that it had to be antiphospholipid antibodies. And then we got the antibodies. So anti-beta 2 GPI was positive and lupus anticoagulant was positive. Anticardiolipin was negative. And the key here is that there have been case reports of mycoplasma pneumoniae and even streptococcus pneumonia causing mycoplasma complications as well as the APLA diagnosis. The reason is that there has to be molecular mimicry. So the beta glycoprotein is actually, very conserved sequence. So many microorganisms, including viruses and bacteria, have that in their envelope. So either in their cell wall or cell membrane. And furthermore, there is also linked with the innate immune system. So basically beta 2 glycoprotein are usually adhered to the endothelium on their cognate receptors. And what happens is that since there is molecular mimicry going on, when you have anti-beta 2 glycoprotein antibodies, they will bind to those receptors on the endothelium, and then they will trigger the activation of toll-like receptors. And we know that toll-like receptors and all those things can cause vasculopathy, can cause thrombosis. So that was the link that the patient might had this predisposition since ever, but the infection, just pulled him over the tip. And that's why all these things happen. So the final diagnosis was APLA, and we gave the patient aspirin, which started him on warfarin with goal to keep the INR between 2.5 and 3.5. And fortunately, after a few days, the graft seems to be healing well. The lesions resolved, the patient's pain resolved, the fever also resolved. And the last platelet count was around 140,000, and the hemoglobin had climbed back up to 12 grams per deciliter. So it was a nice recovery, and you guys rightly tackled it. So thank you so much for amazing discussion. Thanks
for an awesome case, Kirtan, and just really great teaching points. I think we've got time. If Ravi and then Colleen, if you guys want to share just a reflection on thinking through this, we can do that before turning it over to Gabriel for some teaching points.
Yeah, thank you. Antiphospholipid syndrome which is consistent with venous and arterial thrombosis. Yeah, it is an interesting case. I like the case in the sense that it's a complication of this mycoplasma. But however, I'm trying to think how we see so many mycoplasma pneumonia admissions in the hospital. Why this patient was predisposed with antiphospholipid syndrome, which I cannot answer that question. Maybe he's hypercoagulable, hyperviscosity syndrome. Maybe may have some autoimmune component to this condition. Thank you for the case. Thank you.
Thanks, Ravi.
I think my main reflection on this case is in medical school, I think we're taught these like very quick associations between things, just kind of like for testing purposes. Like I knew like a few things about complications of mycoplasma. And I think I kind of anchored on those a little bit early just because it was kind of like the closest thing that like my brain could grab for. And I think just like taking a step back and like thinking about this patient, like aside from the mycoplasma presentation, would have been helpful.
Yeah, I think I have the same reflection, Colleen. I think just starting off with thinking about, right, vasculopathy, right, what could have caused that small vessel disease, I think would have opened up my thinking a little more early on. So I totally agree with you in that. Just it's hard though in real life, right? If someone has an unexpected acute illness and then all of these longer term complications after, sometimes it's hard to sort of separate the two in your mind when you're figuring out what's going on. So I'm totally with you on that.
I think what I want to kind of take away from this case, one is the fact that it was getting worse with cold. I think made us think about like the coldy type processes, right? Like cold agglutinins and cryos and stuff. But I wonder if like when you have an ischemic limb, right, and you hang it lower below the level of your heart, it might perfuse a little bit better, right, no matter what the mechanism is. And similarly, if you have an ischemic process and then you superimpose on that even a normal degree of cold-induced vasoconstriction, then the ischemia might get worse no matter what the primary process, right? So I wonder if there was some of that going on. And then the other thing that is homework for me is the fact that I just called some clinical entities coldy things, all right? And I think I have some room to just strengthen my kind of illness scripts of cryoglobulinemia versus cold agglutinin disease and to what extent they tend to cause like irreversible ischemic damage versus not, to what extent they are associated, each of them, with hemolysis versus thrombocytopenia versus not. Anyway, so that's my take-home point, is that I have some really good things to potentially learn more from this case later.
Gabrielle, let's turn it over.
What a great case.
Yeah.
Thank you, guys. What a great case and discussion. I learned a lot. So for the teaching point, we started with this young gentleman that presented with fingertip pain and paresthesias, and it was noticeable for having a past medical history of mycoplasma pneumonia. So we were start thinking about some complications of this disease, especially in a young patient that presents with also a dark urine. We want to start thinking about paroxysmal cold hemoglobinuria. And maybe if an older patient, we also want to start thinking about cold autoimmune hemolytic anemia or cryoglobulinemias. Another immune-mediated diseases associated with mycoplasma pneumoniae are, for example, antiphospholipid syndrome and sometimes of vasculitis. Also, the patient had a flu finger syndrome. So the differential diagnosis of these conditions are, for example, in the embolic bucket, we have arteriosclerosis, arterial aneurysm, a disease that is produced by a cardiac thrombi, for example, cardiac vegetations or atrial fibrillation, antiphospholipid syndrome, and paraneoplastic. Also, the predominant pathophysiology is vasoconstriction. We could start thinking about lupus or this disease that is called perniosis. If this condition is mediated by some type of inflammation, we could start thinking about syphilis, Behçet, thromboangioitis obliterans. And if it's a problem of the circulation, we can start thinking about hyperviscosity syndrome, myeloproliferative syndromes, or cryoglobulinemia. Later, we noticed that the patient had a thrombocytopenia and anemia. So Sabin taught us a lot about this condition that is thrombotic microangiopathies. And we can divide this in two big categories, primary and secondary. So in the primary, we have TTP, Hughes, and DIC. And on the secondary bucket, we have autoimmune conditions such as phosphoautoimmune syndrome, scleroderma renal crisis, and some types of infections such as strep pneumonia, HIV influenza are sometimes drug-induced, such as chemotherapy, clopidogrel, tacrolimus, and also malignant hypertension. But we have to start thinking about this condition in the case we see schistose on the peripheral smear. If we note, and such as in this case, and the PTT didn't correct, so we have antiphospholipid syndrome and some medications as a heparin on our differential diagnosis. Later, Marie taught us in the chat a nice part about autoimmune phospholipid syndrome related to some types of infections. So those are hepatitis C virus, Epstein-Barr, parvovirus 19, cytomegalovirus, HIV, SARS-CoV, recently SARS-CoV-2, and on the bacteria bucket, we have syphilis, TB, malaria, Lyme, and mycoplasma. So I hope you guys enjoy this case, and thank you for plugging in. Have a nice day.
That was amazing, Gabriel. Thank you. And Kirtan, what a great case. And thank you for that. Colleen and Ravi, it was a pleasure. Thanks for volunteering and discussing with us. Hope everyone has a great day.
Bye.